Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sack here. Today, I'm once again joined by Dr. Douglas Drossman, Professor Emeritus of Medicine and Psychiatry and Gastroenterology at the University of North Carolina School of Medicine. Last time out, we had an amazing discussion about many things, and we're going to pick up again as I join Doug and his poop emoji friend sitting off to his right-hand side. Doug, how are you?
I'm doing okay, and how are you?
I'm fine and dandy. Thank you very much. I'm keen to dig in again. When we left off last time, I was about to ask you, and we're going to put some links in the show notes. Can you talk to us about the books that you've written, the recently published Gut Feelings series? You can go to gutfeelings.org. And again, we'll put it in the show notes. Tell us more about the most recent book in the series, Doctors and Patient-Centered Care, How Knowledge, Commitment to Care, and Empathy Improve Patient Lives. So first of all, tell us why the book series, and secondly, tell us about that book and the key take-home messages for clinicians.
Okay, I'll give you as a brief introduction the first two books and then focus on the third. It really was COVID. I've been doing a lot of traveling internationally, giving presentations and committee meetings. And with COVID, I was stuck home, and I decided to compile a lot of my work. And the first book, called Gut Feelings, Doctors and Patients. Now, the first book was called Gut Feelings, Disorders of Gut-Brain Interaction in the Patient-Doctor Relationship. And that focused on all my work about communication skills, how to interact with patients, and also about these disorders like irritable bowel and the like. That's been extremely popular. Several thousand books have been sold. Doctors give them to their patients. Patients sometimes read them before they come to see me. And then that led to the second book, where I got 8 of my patients who were struggling with their disorders and got better under my care. And they wrote narratives about how they got better and why. And that became very popular for patients to see what their journey was like with other people. Then I decided, why not close the loop? And what I meant by that is to say, what about all these doctors in what we call neurogastroenterology who are very effectively treating these patients using good, effective communication skills, listening and talking with their patients, communicating well, and having good knowledge about these disorders where there's no structure. It's not IBD, it's not pancreatitis, it's IBS or chronic pain. So I compiled 14 doctors around the world who I knew through the Rome Foundation and other groups, including myself, and gave them a series of questions about their life, what made them go into this field, and what made them famous. All of them were very famous in their field. And there were several factors that came up. And what I did is got all their information, compiled the chapters, and then did an epilogue where I saw where the similarities are, what made them special. And what came up were about 7 or 8 items. The first was many of them had early cultural or family influences, coming from a second generation where the family wanted them to have the American dream. Others where the family was involved as doctors, where there was early exposure to medicine and medical illness. Many of them had illnesses as a child or their family members did. Another factor was all of these people had a mentor. They had someone special in their field. Mine was George Engel, a psychiatrist and
Yeah.
internist. Yes. And everybody had a special mentor that allowed them to go through the hard times. They could rely on them to help them when they were having problems. Next was that they worked in patient-centered care, not doctor-centered care, meaning that it was the patient who was helping them make the decision. They weren't telling the patients what should be done. Another thing that happened was that they had mistakes and failures. It sounds interesting to hear that, but many of them had problems. I had what was called imposter syndrome as a resident. I didn't feel I knew anything, and this went on for a year until I was able to recover from it. And when I talked to my partners and my other patient providers, they all had the same. Not all of them, but most of them at least acknowledged it.
Can I interrupt you briefly there, Doug, to say, um, there's that quadrant, isn't there, about achievement and character, and the worst in the world are people who are arrogant and ignorant, and the best in the world are people who are wise and humble. Being wise and humble defines having imposter syndrome because it drives you on to achieve more because you don't feel like you've achieved anything, and it keeps you humble. I don't, everyone rags on about imposter syndrome because I've sure as heck got it. And I think I love it. I love it because it drives me to want to actually do something with my life.
And it allows you to be open to someone else about it, which
Yeah,
then provides support when other
yeah,
one.
absolutely.
But the ones who are hyper ego, they don't want to admit it, so they struggle inside and
Yeah,
they make more
good point.
failures.
Good point. Sorry to interrupt you.
Yeah. Um, they also had what we call from the Greeks eudaimonic experiences. Uh, you've you've heard of hedonism, which is pleasure. The Greeks had hedonism and eudynis, eudynamism. Hedonism is pleasure. It could be sexual, it could be food, it could be playing sports. It's pleasure. But eudynamics is getting meaning, special meaning out of the experience. So you can like going to a good restaurant, but if you are a connoisseur of food and teach it and you enjoy teaching it, that's more of a special arrangement. And so these are people who treated patients and they get special pleasure out of doing that, the experience itself.
Hmm. That's
Um, what else was there? Let me see. I think that was most of it, and that really drove them. And from that, we publish the book. When we go to meetings, we usually have them sign the books, and it's getting increasingly popular. Now, this is in the field of gastroenterology, but there's really very little I'm saying here that doesn't apply.
I'm sure. Yeah, it applies everywhere. And some key take homes for what can the average clinician reading one of these, what would be the aha moment? How would it change their life?
That working with patients is not a one-way place. It's a collaboration. And by being collaborating, by collaborating, you both share the experience and you both benefit. If you're directing the patient, then you're totally responsible for failures, and that doesn't work well. You want to share it.
Makes sense. Changing topic a bit, first of all, thanks for that. Your Institute of Medicine committee work showed how war trauma led to post infection IBS amongst deployed soldiers. From this, the Veterans Administration, the VA system, approved medical benefits for veterans thus afflicted. Can you talk to us about that work, please?
Yeah, in the early 2000s, I was invited by the Institute of Medicine to work on a series of books to write a chapter, work with the committee, who were people, epidemiologists, surgeons, psychologists all over the world, all over the country mostly, um, on what was then called Gulf War syndrome, which were the effects of the Gulf War on physical and mental health.
Yeah.
Things that came up were post traumatic stress, drug addiction, uh, severe depression and anxiety, and they found they were having GI symptoms. So I was called to come on this program, and we worked for 18 months. We interviewed soldiers, we interviewed experts, and we came up with chapters. And in my chapter, we found that irritable bowel syndrome and functional dyspepsia were extremely common. And the reason why it seemed common was that these post infection disorders were conditions that were a combination of exposure to an infection, bacterial, viral, parasitic even, among these soldiers. 80 to 90% of them had exposure, but in addition to that, they were in an experience of high stress. And the concept of post infection IBS and dyspepsia relates to the severity of the infection and the stress environment. My work was associated with abuse, early trauma, sexual physical abuse. But war exposure, exposure to a war, was also a kind of abuse. They were fearful of dying, and that combination led to the condition developing. I presented that to the through the Institute of Medicine to the Veterans Group, which was the group that was supporting this effort, and they then decided that anyone who developed IBS or dyspepsia under deployment or afterwards would be provided full VA benefits, whereas before you had to prove it. So that was the bottom line of that, and that's continued.
Yeah, interesting. No wonder that these folks were in a stressful environment. I can't imagine anything more awful. So you also improve knowledge relating to the you've mentioned drug addiction in veterans, but you also improve knowledge relating to the effects of opioids within gastroenterology, and you published on opioid induced constipation, something that we all know about, and you characterize narcotic bowel syndrome as an entity of opioid induced central hyperalgesia. Your detoxification program is now used globally. Educate us, please.
Well, you just said it.
Yeah, well, I mean, I'm just repeating what you did, but how did you
Yeah.
tell us the journey? I mean, I remember learning about it. You get opioid, you give people opioids, they're going to get constipated.
Yeah, the constipation was known. What wasn't known was the hyperalgesia. And because I was seeing so many patients with um, chronic severe abdominal pain who were on high dose narcotics, they would come to me or be hospitalized and they'd be on extremely high doses and they were no better. They were worse. And then I raised the question, could the opioids in some way be playing a role in them not getting better and actually having more pain? So what we did was we hospitalized them and we put them through a detox program in medicine, not psychiatry, where we instead of the way you treated the opioids back then is you give them a dose of opioids, and if 3 hours later they weren't better, you gave them another dose. And what they were going through was called a soar and crash. They get better, but then as they withdrew, the pain got worse. So we gave them their full dose for the day in a continuous IV dose throughout the day, and we gradually reduced the dose about 10 or 15% each day for about a week. And we were surprised to hear or see that their pain got better. They actually had a 75% reduction in pain the first week. And if they stayed off it, we checked back with them 3 months later through the North Carolina registry. And if they stayed off it, they were another 25% better. Um, and if they went back on it, their pain came back. So we started to publish that. And then later work showed that opioids affect the glial cell uh, in the central nervous system that cause uh, enhancement or hyperalgesia. So it actually was having an opposite effect.
That's fascinating. Um, a bit of a broad ranging question, speculative. You've got very extensive research and clinical experience over many years. What future developments or breakthroughs do you expect to see in the field of, in the field you work in? Um, what's at or just over the horizon that has Dr. Drossman excited?
Well, not directly in my area, but what I do see happening is more and more interest in the microbiome and its effects not only gut function but brain function.
Sure.
In fact, we call it the microbiome gut axis now in some of the newer publications. I think there'll be more of that. I think we'll be learning about that. One of the things that I think would be very valuable is to start to focus on central management of gut symptoms. We use antidepressants and antipsychotics and anti anxiety. We're borrowing them from psychiatry. It's all off label because pharmaceutical companies don't really have groups that look at central effects on GI function. It's either peripheral or psychiatric. So you don't see a phase 3 study treating irritable bowel, for example, with a new drug that acts on the central nervous system, going beyond the antidepressants, something that works more specifically in pain control. That's something that I think would be very valuable. Another thing that I think would be very valuable would be increased education and support for that education to providers on patient centered care and collaborative care, the kind of work I'm talking about, because it's not what you do, it's how you do it that make a difference. You could prescribe a medication, but why does one get better and another not? It could be pharmacogenomics, it could be genetic factors, but having looked at both, a lot of times it's the relationship with the patient owning it. When you look at my second book on narrative, the patient's narratives, when they talked about getting better, it was how the relationship and their trust in the doctor and their confidence in the treatment made the difference, not just the treatment itself.
Yeah. Well, it comes down to how we teach medicine and how we recruit people to go to medical school and then into their specialties, and um, what we focus on during the limited amount of time we have at medical school to teach people how to be doctors. And now there's very good evidence that your approach makes perfect sense. So I would hope that that's closer than at or over the horizon. Doug, again, a pretty broad question. You've had received numerous awards recognizing your contributions to medicine. Tell us about your high and low points, the proudest accomplishment and a career low point.
Well, I think one of my highest accomplishments has been um, almost in a Sisyphusian role early in my career, going upstream all the time and meeting a society, a medical society, where there was extreme doubt on the things I was proposing. The role of psychosocial factors in GI illness, what we call the biopsychosocial model, which was taught to me by my mentor, George Engel, who I mentioned before, that to treat properly, you have to look not only at the biologic, but their psychosocial world. And that was an uphill battle. Um, and that was a challenge. And what really led to benefit was to keep going at it and to bring in together partners in the relationship. The partners were people of similar interest and similar training who believed in the biopsychosocial model, who believed in patient centered care. And we formed our own group. It was called the Brain Gut Research Group back in the 90s. And then we worked with the AGA and we became very dominant in the group. And pretty soon we were controlling many of these disorders for abstracts and symposia at the meetings. And that led to us forming an international group called the Rome Foundation. And I think that's my greatest sense of accomplishment, that we have a global effort, just like in psychiatry, there's DSM 1, 2, 3, 4, 5. We're now coming up to Rome 5, which will be out in 2026. And so we're teaching the world about these DGBIs, these disorders of gut brain interaction, and about communication, the role of psychosocial factors. That's my greatest. I think being able to introduce the world into the role of abuse, which had been, when I first published my first paper on looking at abuse and trauma in GI, it was in 1990 in the Annals of Internal Medicine. It was the first and only paper looking at medical, not just GI, but medical. Up until that point, it was only in psychiatry. And the other accomplishment would be the effect of opioids, that you have to really consider not to use opioids for chronic illness. and I think that's becoming much more accepted these days. Um, my teaching of communication skills is really my dominant interest now, outside of the practice, where I run workshops, train the trainer programs, and I have to add this. I am very excited now on using AI, which has its good and its bad.
I was actually going to ask you about that because you were telling me that you were creating avatar patients and using AI to train them so that they could be used to teach doctors better communication skills. Tell us about that use of AI and then any other comments you have on the topic.
Yeah, well, the prelude to that were the videos we've done. Part of the written word is not as good as the video to teach. So when I go to workshops, I show a simulated video with a partner of mine, Johanna Ruddy, who's a patient, was a patient of mine, and has since gone on to collaborate with me in facilitating workshops. And she's an excellent actor, and she plays all these roles of patients not wanting to go on a neuromodulator or wanting opioids or wanting a CT scan when she had one 6 months ago. Um, and I do simulated interviews with her, and we have teaching sessions with providers. Well, I came across a brilliant guy. His name is Rishank Saini, who has a company called Soma Labs, and he um, creates education for medical school students on using avatars to teach them patient care, but it was how to do a history and physical. What I was teaching was complex interviews. And so what we did is we sent him everything I've written on communication, all the videos, and they compiled this into this giant database. And then they would create an avatar who had the problems of those videos, and I would speak to the patients. So, for example, we one of the simulations was a 17-year-old girl, adolescent, who was in a women's school, who came in with a GI bleed, an upper GI bleed from GERD, from reflux. And if you do the interview well enough, she will tell you that she has bulimia. She has an eating disorder. But if you ask her straight out, she'll deny it. But if you build your relationship, she'll tell you. And then you ask her about what are the stresses that make her do it. And she says, socially, there are problems. And if you let it go at that, that's it. But if you pursue it further, what social? She says. Then she says, "Well, my boyfriend, I'm leaving the school, and he's forcing sex on me, and I don't want to do that. I feel I'll do it when I'm ready." And if you leave it there, well, there you are. But if you say, "What's making it so stressful for you?" and she starts to cry, and she talks about early childhood sexual abuse, which made her so reluctant. But you couldn't get to that level unless you were good. So this avatar gives you hundreds of different responses and scenarios based on the same history. So that's what's really exciting. And I find when I'm teaching, you can have different providers get different information from the same patient.
Yeah. I mean, the use of these technologies, augmented reality, virtual reality, avatars, AI. I mean, it really is. It's interesting. Humans creating computers to be better. Now the computers are hopefully helping the humans to be better. So
Right.
fascinating use of artificial intelligence. We're running out of time, Doctor, and I always like to ask people if they found a magical genie that granted them three wishes for their professional areas of interest, what might your wishes be?
Well, I think global acceptance and use of the biopsychosocial model in research, teaching, and patient care. And along that lines, I think there has to be um, teaching, funding from federal agencies, from grants. I mean, it's very hard to get grants these days if they're not translational or basic science, even clinical to some degree, but biopsychosocial is very hard. Um, and I think I want to teach the communication skills, continue to do that, and develop a legacy of providers who can teach in the same way because I feel a little bit alone in some of this teaching. because my training is in GI and psychiatry, and there aren't many doing that. But if I could train people to do that and have them carry on the work, that would be great. And then, of course, get the patients and the providers to work together in this patient-centered collaborative care. Those would be my main genie hopes.
Mm. Well, what strikes me, I mentioned before about being wise and humble. I think if there's anyone to get the message out, it's you. We just need to help you get the message out, and we'll certainly put all the relevant links to the Rome Foundation and your books in the show notes. And I have to say, total pleasure talking with you, Dr. Douglas Drossman. You are a delight. I appreciate your time.
Well, thank you. If I could just say back, I don't think I've found an interviewer who actually read what I'm doing in order to formulate your questions. That's unique and special. So thank you for that.
Well, it's kind of you, Doug. I like to go to bed less stupid, and I like meeting smart and nice people. And I still can't get over the poop emoji. It cracks me up. So, folks listening in, I'm sure you've enjoyed this. Please subscribe for the podcast so you never miss an episode. Check out the archives, there's a few hundred in there. Leave comments, write reviews, tell your friends, blah, blah, blah. That all helps us continue to do this. It's a labor of love. Please join us next week for another fascinating episode of the EMJ podcast. And in the interim, please stay safe, stay well, stay curious. Bye for now.